Welcome everyone to today's session from the All Party Group on coronavirus, where we'll be looking at living with long COVID. Believe it or not, it is now just over a year since we led the first debate on the floor of the House on long COVID. And this is now our 6th session as a group looking at this. We have, of course, awful stories that we all get in our inboxes all the time. Please excuse the bell. But the purpose of today's session is to hear from people with lived experience and to also hear from clinicians who can give us a bit of an update on what we know now and what is available. So we'll be running two sessions, 45 minutes each. And I'd like to start by introducing our panelists for the first session. So first of all, welcome Ravi Varayajak. Prior to falling ill with long COVID, Ravi was a healthy 23-year-old who had just graduated from Stanford University and was starting a master's degree at Tsinghua University as a Schwarzman scholar. Sorry if I mispronounced that. However, he's now been very ill with long COVID for 10 months. His main symptom has been overwhelming fatigue, and this has forced him to spend 16 hours a day in bed, which has prevented him from doing work, let alone living with anything resembling a normal life. Ravi's currently based in London. Thank you so much, Ravi, for joining us, and we appreciate the effort that you've made to do so. We have Colin Pigeon with us. Welcome, Colin. Colin is father to Rosie, and Rosie sadly can't join us today because she's not well enough. But she is 16 years old. She's been living with long COVID and she suffers from a range of physical symptoms and has been unable to return to school since contracting 19. So thank you for sharing your family's experiences with us today, Colin. It's much appreciated. And we also have Rebecca Logan. Rebecca is a 41-year-old staff nurse, fitness instructor, wife and mum of 2. Who had contracted COVID-19 from working in a COVID emergency department on the 7th of April, 2020. And since then, she's been extremely debilitated with long COVID. Her ongoing symptoms include crippling fatigue, brain fog, muscle and joint pain. She uses a stick and a wheelchair and states that she is 80% housebound assisted. Thank you all for coming to speak to us today. And we do not underestimate the special difficulty in doing so. If at any time during this session you feel too tired, you need to drop off, it's just too much, please don't feel at all embarrassed about just saying, I can't continue, thank you, and just go. Don't feel any at all. We understand completely. I wonder if we could start by simply setting the scene. If we could start in the order that I introduced you, just giving us a brief outline of your current circumstances. When did you get COVID? What symptoms do you still experience? And how has your life changed? Perhaps we could start with Ravi, and Ravi in particular. So what's it been like as a young person?
Yeah, well, living with long COVID as a young person has been very difficult. Prior to falling ill, I was a healthy person in their early 20s who lived like someone in their early 20s, and that I didn't pay much attention to my health. I kind of threw myself around and tried to live quite a lively life. But I've kind of completely lost that life. For the last 10 months, I've had to spend, until recent improvement, around 16 hours a day in bed. And I'm unable to do all the things which kind of made life meaningful and joyous before. To give you a bit of background on my kind of the medical side, I don't actually know exactly when I contracted COVID. I belong to the sizable minority of long haulers who developed long COVID from asymptomatic infections. And at first, it didn't really occur to me that I had long COVID. I thought it was something more like ME or chronic fatigue syndrome, which I knew a bit about. And it was only when I paid more attention to my secondary symptoms, in particular, that I'd lost my sense of smell and that my sense of taste was much diminished, that I realized that I probably had long COVID. And that was then corroborated by the UCLH long COVID clinic. But yeah, now it's been 10 months of living with this illness, and above all, living with this fatigue, which is so debilitating and has really taken my life away.
Thank you for that. And Colin, what's been the experience of your family and Rosie in particular?
Well, Rosie, she did her GCSEs last year. And so she was, I think, on her second day of school, just starting her AS levels. And she was pinged and as a close contact. And so we arranged for her to have a test the next day, which she had. It came back negative. Then the day after that, she was drinking, I think it was orange juice in the kitchen. And she said, "Dad, I can't taste this." So we booked her back in for a second PCR. Again, it was negative. But given that she had symptoms, we figured that it was the right thing to do to keep her off school. And so she stayed off, and then she did the day 8 test, which again was negative. So she'd never tested positive for COVID. During the acute phase, she had a couple of days when she felt a bit rough, very, very mild. And I understand this is quite common, and particularly amongst children. She had a bit of a headache. She was maybe more tired than usual, a little bit of a temperature for a couple of nights, I think. And then on the day that she was due to return to school, she was going to get in the shower, and the shower room's off our bedroom. So she was just about to go through into the shower room, and she said, "Oh, I think I'm going to faint." And then she very nearly did. Then subsequently, she's had several fainting episodes. It takes her ages to get out of bed. She has to do it very slowly. We're getting her investigated for a symptom called POTS, or a condition called POTS, which something to do with her autonomic nervous system was out of kilter. Yesterday, she was sitting at the table with me in the kitchen. Well, I working from home, so I can look after her. She was sitting at the table with her lunch, and her heart rate was 140, which for a 16-year-old girl is not right, clearly, when she's sitting. So she has issues going on with her heart rate, particularly. Like Ravi said, fatigue, yeah, the payback from doing anything is excruciating for her. And which is why I was very firm and decided not to bring her on today. She really wanted to. She wants to speak for other young people. Sorry if I was too upsetting. She wants to speak for other young people, and give them a voice. She was really courageous and did an interview with BBC Northern Ireland. It was a couple of weeks ago, and it took her 2 days to recover from it. And I can see Rebecca's nodding her head. She's done similar things, and actually she's one of the people that inspired Rosie. She hurts all over, muscle pain. If I were to pick one thing, that I can't pick one thing that's the most worrying about what's affecting her. She's had a headache since the start of September. We paid privately to have an MRI of her brain to try and, to exclude tumors and lesions and things that possibly, inflammation, that sort of stuff. But the most upsetting thing for me is the impact it's had on her cognitive ability. I said that she'd just done her GCSE. She got A's in everything apart from German. I think she got a B in German. She let us down on that one. She's a very bright, articulate young woman, and she's also extremely fit. Or she was. She was a championship Irish dancer. She could keep up a fast, heavy, or what you call a triple jig, which is like a fast dance on the heavy shoes like you would see on River Dance, for like 3.5, 4 minutes, which is real intensive workout. And now she can climb the stairs, and then she has to sit at the top of the stairs feeling dizzy and sick. So
Colin, thank you so much for sharing that, and please tell her that we completely understand, and she is, through you, speaking up for young people and their experiences, and she's very, very brave for even agreeing to consider speaking to us. So please thank her on our behalf. We're really really grateful to her.
Okay, I will do, yeah.
We hope to do our best to get that message and that story across today. So thank you.
Thank you. Thank you.
And to her hero, Rebecca.
Well, I don't feel like a hero, but I appreciate that. So I, pre-COVID, as you said, Leila, I was an ED nurse and fitness instructor. I worked 12 to 18 hours a week in my local ED and taught 12 to 14 high impact fitness classes a week, including running my own fitness business. And I'm a wife and I have 2 girls who are 12 and 14. I contracted COVID-19 on the 7th of April 2020 after working in COVID ED with inadequate PPE. I was not hospitalised, but had to attend ED on 2 occasions in the first 5 weeks following infection due to breathlessness and other breathing issues. I felt my symptoms had improved slightly from June to August 2020, and I tentatively began exercising and teaching a few classes. I could not return to nursing as my brain fog and cognitive function was not good. Initially, exercising was okay. However, after 4 weeks of doing this, 4 to 5 times a week, I was becoming increasingly fatigued, breathlessness worsened, I had tachycardia at rest, I was cyanosed, and my ability to complete a class or a short walk got less and less. I was advised by a neurologist and cardiologist to stop and rest, which I did so at Christmas 2020. I thought I'd be fine in a month or so. However, I gradually deteriorated to the point I'm at today. Every single day I waken as if I have not slept. The fatigue is crippling. I have tinnitus, brain fog, cognitive dysfunction, joint pain, muscle pain and weakness, poor circulation, breathlessness, and runs of tachycardia. I don't live, I exist. I now need to use a wheelchair. I can only drive very short distances to collect my daughters from the bus stop, which is about a 2-minute drive away, and I can do this twice a week maximum. I'm basically housebound unless someone can take me out. I can manage a social situation for a maximum of 1 to 2 hours. Otherwise, my speech slows and the lead curtain of fatigue, that I call it, starts to come down. My husband and children are now my carers. I can't cook a meal, and drying my hair is a challenge. I don't recognise the life I have now, and to be honest, if it wasn't for my family, I would not want to continue living like this.
Goodness, Rebecca, thank you. And again, thank you for sharing that. And I saw Ravi nodding when you said the lead curtain of fatigue. It sounds like there are many with that experience. If I can now pass to Lord Russell.
Yes, thank you, all 3 of you. Ravi, if I could ask you first, what support have you been given so far through your GP or a long COVID clinic? And how soon were you able to access support?
Yeah, so I've been in quite regular contact with my GP from relatively early on the illness. And he's been very understanding and supportive. There are 3 things he's done. The first was giving me a whole set of blood tests so as to rule out various other illnesses. The second was offering me psychological support. So he referred me to the Camden CBT Centre, and that was helpful, but it didn't address the root problem. Living with long COVID is very, very difficult psychologically, and yet long COVID is a physical illness. So if you only treat the psychological side, you're only treating the secondary effects of living with a very debilitating illness that takes away your life. What I really needed was medical treatment. And I hope to get that from the UCLH clinic, a long COVID clinic, which my GP then referred me to. And I had a positive experience with the UCLH clinic. They were, again, very understanding. They offered me 2 things. The first was advice on symptom management, how to kind of manage my fatigue in terms of activity I do. And they also prescribed me some antihistamines, which so far haven't really had any impact. So the really frustrating thing for me is that I've been ill for 10 months, and yet through the medical system, I haven't been offered any medical treatments which directly target my symptoms or alleviate my symptoms. And especially as a young person, it's just, it's very difficult to wrap my head around that. And it's enormously frustrating that medical treatments haven't been able to give any of my life back.
Thank you very much. Colin, could you tell us about your family's and Rosie's experience?
Yeah. So Rosie was, let's see, so it was the start of September when this first started with her. And then it was, I guess it was the start of October when she was referred by our GP to pediatrics. She'd had a series of blood tests like Ravi, you know, rule out things like whatever, like low iron or, you know, that kind of stuff that they would look for, maybe diabetes and things that can cause dizziness or whatever. So she was referred for an urgent pediatrics appointment. I think it was like the 12th of October, something like that. And when I rang the hospital appointments line, it was the 1st of November when the long COVID clinics in Northern Ireland were first announced. I spoke to our local hospital, the outpatients thing, and they told me that they were currently seeing the urgent pediatric referrals from June. So it was likely to be February or March before she was seen. Now you can't leave a child with a crippling headache for 6 months before they even see a specialist. So we paid to go to a pediatrician privately, and he's arranged a whole load of tests, which have cost me a lot of money, and so far have shown, well, they've ruled out lots of really nasty things that obviously we want ruled out, but what they haven't done is pinpoint anything that helpful. After Rosie's TV interview, which was, you know, I tweeted a short version of it, and she got a phenomenal response, praising her for her courage. And I also got a message from, or actually several messages from various people who have medical experience, including a guy that I used to rock climb with when I was a teenager and haven't seen since my brother's wedding in like 2001 or something. And he said, we're seeing a lot of POTS at the moment. It sounds like it could be that with the dizziness. Get that checked. So we went for an assessment with the GP. There's a fairly simple sort of diagnostic test: stand up, measure heart rate after a period of time to see if it goes back down and stuff. And it was sort of inconclusive. Her heart rate went, when she stood up from the sort of couch thing, her heart rate went up to 129 or something, which I suspect it shouldn't do. But it did come down again, and came down probably more quickly than you might expect to if it were POTS. But she's obviously got something going on with her nervous system. But if I can rewind from all of that stuff, the other thing that on the 1st of November, I asked our hospital about was the long COVID clinics, and when that might be coming around. And I was told that the first they had heard of them was when it was announced on the news. Unfortunately, they didn't have any clinicians in place, and so on and so on. So I left it for a while, rang back again after a while, passed around various places. And this is one of the things that was really difficult. I had to make several phone calls in order to get to even get to the right place. Now, if I were in Ravi or Rebecca's position of crippling fatigue and brain fog, I don't think I would have been able to battle my way through the system. You know, I'm healthy, I'm well, and it's a struggle for me, you know, to do it on Rosie's behalf. I then discovered that she actually couldn't be treated by the long COVID clinic because it was for over 18s only. But the lady who I eventually got speaking to a clinician somewhere in one of the sort of community hospitals, I think in Belfast, and she said she's been charged with running the clinic for under 18s, but it hadn't been confirmed or commissioned by the Health and Social Care Board, which commissions services from the Northern Ireland trusts. It's a complicated system, right? But so she was waiting on confirmation. She said she would ring me again when she was straight back after she was returned to work after Christmas in January to give me an update, which she did. There was no update apart from, no, we still haven't heard. And then once, I suspect the cynic in me says, when the BBC rang the Health and Social Care Board and said, do you not run these for under 18s? Somebody then made a decision. Anyway, I mean, about half an hour before we sat down with the journalists, we got a text saying, just heard from them, they've confirmed that they will treat 16 to 18-year-olds. So that gets Rosie into the system. She has her first appointment and assessment on the 24th of January. So we'll see how it works. I mean, I've read plenty about these clinics, and they can be a very mixed bag. If anything, all we're looking for at the moment with her, because we're getting a lot of medical investigations done privately, we need stuff just to make her life bearable, because it really isn't.
Yeah. Colin, thank you very much. Rebecca, could I ask you the same question, please?
Yeah, sure. I've had very little help from my GP and absolutely nothing from a long COVID service in Northern Ireland. I was told by my GP in October 2020, whenever I phoned in desperation for some answers about why I was feeling so unwell, he told me that I was anxious and depressed and prescribed antidepressants, despite me arguing that, you know, this was a physical condition, but I was dismissed and told to get on with it. And I have been campaigning in Northern Ireland from September 2020. And then to try to get answers and to get help. And then eventually, whenever the World Health Organization recognized long COVID as a condition in January last year, I started to speak out more in the media for help in Northern Ireland specifically, because in England there were clinics, you know, from June, July time. So I then started a network of people who have long COVID in Northern Ireland, who have contacted me over the last year, particularly because of the way I've spoken out and advocated. But I mean, really, we've all had to look for help ourselves. And as Colin said, you know, he finds it hard as a well person. As an extremely unwell person, it is very, very difficult, especially with brain fog, cognitive issues, and you lose. I mean, I feel I have lost my I've lost my ability to speak. Well, I can speak for myself, but I've lost that confidence that I know I'm right, because personally, and for many other sufferers with long COVID, we've been disbelieved and dismissed and had constant gaslighting. So we've actually withdrawn into ourselves or into our own community and not actually probably sought the help by our GPs that we probably should have demanded. I was fortunate that I had a colleague who's a consultant in my local hospital who agreed to see me, and he then sent me for some tests, which is quite common as well. They came back normal, nothing, you know, obvious of the routine test that you would do. But the most help that I've had has been from a charity in Northern Ireland, the Northern Ireland Chest, Heart and Stroke charity. And from July 2020, they recognised that COVID-19 wasn't just a 14-day illness. There were lots of people contacting them because of the nature of their charity, the areas they focus on, that they realised that, you know, they needed to do something. So they then adapted a chronic conditions recovery program that they ran to facilitate long COVID patients. They still carry that on, fund it, and it's a charity, which is very frustrating as a health professional myself, to feel so disheartened and disappointed, you know, from the services that haven't been provided. And I'm 21 months down the line here, and I've come to Germany to be believed, to be treated, and to be hopefully can develop something that will help others. But I mean, it's not good enough that charities are really the only thing that seem to be helping people. And also Northern Ireland ME charity, Hope for ME and Fibro, they've been amazing. So from my point of view, and I've had nothing from a long COVID clinic. I mean, I got these, so I met with Health and Social Care Board in Northern Ireland in July 21. And I wanted to, say as a patient what I felt would be helpful. They'd already made their plans, which included CBT and pulmonary rehab, nothing about tests or treatments. And the services that they said, they haven't even come into effect. I was referred on the 12th of November to the long COVID clinic in Northern Ireland. I haven't heard anything.
Yeah.
So it's just my experience has been, and I'm not isolated in that either.
Yeah. Not good. Rebecca, thank you very much.
Can I just quickly ask, are you self-funding?
Yes.
For going to Germany? It's totally off your bat, not in concert with the NHS at all?
Oh, nothing to do. No, not with it. It's totally self-funded.
That is completely scandalous. That's scandalous. I'm so sorry to hear that. Hopefully they're giving you the help you need. If I can now pass to Paul Strasburger. Lord Strasburger.
Thank you, Leila, and thank you to the panelists. Thanks to all of you for coming along today. Rebecca, could I start with you? You've already partly answered this question, but I think we could get a little more detail. What support do you need that you're having trouble getting? And I suppose I mean by that, you're having trouble getting in the UK. What is it that you've had to go to Germany for, and how hard did you try to get it in the UK?
Okay. Well, what priority I think for me and many with long COVID is to be believed and stop this gaslighting and stop psychologizing long COVID, because there is evidence proving that it is a multi-system vessel condition. We need clinics that are face-to-face, led by a team who are educated on long COVID, where appropriate tests are carried out to exclude underlying conditions that have been caused by COVID-19, which we know this happens, such as dysautonomic states like POTS, post-exertional malaise, and microclots. And for treatment that we get, it is based on current research on long COVID, to be carried out, like HELP apheresis and anticoagulation therapy, which is what I'm receiving in Germany. It's a key priority that we get this diagnosis of microclots and hyperactive platelets recognised in the UK. And we have Pretorius, Kell and Jaeger et al. Study, which is going to be published in Germany soon to show this. And this is identifying microclots and a significant platelet dysfunction in each of the long COVID study patients. So it's not something that's just being thrown out there. We've got the evidence, so we need it to get it in the UK. I mean, I have tried to get blood tests from my GP, and blood tests that aren't just routine. And the answer is, oh no, we don't do that. You need to go to your emergency department to do that. Well, the emergency department is already under stress. How would I turn up? It's not an emergency in their eyes. But we just need to stop being dismissed. I mean, it's constant. Everyone feels they're being dismissed. And to look at the research that is coming out, like it's weekly, it's evidence. It's not just, a few months ago, it's constant, and that research is acknowledged and acted upon in the UK, rather than just sort of, oh, well, that doesn't fit our standard medical practice, that we maybe have got used to in the UK, that we maybe need to look outside the box and, do things that maybe are not seen as routine in the UK. And just because it has to adapt, we can't keep living like this. I can't go back to my jobs. I am a shell of the person I was. And it's not in my head there are so many. And I mean, it's been quite overwhelming coming over to Germany and meeting others from around the world who have come here to get treatment for long COVID. I mean, that's just, you know, and they're funding it themselves. They're having to pay things. And, you know, it's just, it's quite extraordinary. And if you wanted to check out the study, there's a YouTube video that's just gone up from the Long COVID Foundation where Dr. Marek Fabrowski goes into this in more detail. And it's just, it's amazing work that's happening over here. But why can we not get this in the UK? We have the machines, we have the diagnostic tests. We just need to look outside the box.
Rebecca, who is it that's not believing you?
GPs, consultants, other health professionals. You could go to, I mean, when I went to a neurologist, she said, oh, I've never come across anyone like you with long COVID. But I think the problem is that because the waiting lists are so long, the people with long COVID are waiting months, like Colin said, for help on the NHS. Not everyone can afford to pay privately. I can't afford to pay privately. Colin can't afford to pay privately, but we're desperate to get some answers. So these people are, you know, even when you go to see them privately, they haven't actually, you know, seen many people like us. Do you know what I mean? So it's like, well,
is it because they've got no answers, or they just don't believe you?
I think it's a bit of both. I think that it's, you know, there are no experts yet on long COVID because we're all learning, but there's a lot of research and concrete evidence out there. I can't get my head around the fact that there is so much happening around long COVID in Europe, but yet in the UK, it feels that that information is being ignored by health professionals, consultants down to physios, OTs. We've been questioned on it's all about your psychology. Anything I've been to related to, and any feedback I've had from people who have had any sort of contact with long COVID clinics in Northern Ireland, it's all about CBT, counselling, and rehab, exercise. Well, I was a fitness instructor. I can't exercise. I can manage to walk for 1 minute. And even at that, that's enough to put me off my feet for the rest of the day.
Well, I think we're going to explore whether we've got something to learn from other countries in the way we go about treating long COVID in the second session. And so you've certainly given us a hook for that. So thank you very much. And Colin, do you want to answer that question? Any support you're trying to get that you can't get?
Well, at the moment, I mean, we have a good relationship with our GPs. Our GPs are great. And for example, when my friend sent me the article about how to assess and diagnose POTS, I rang the GP and they booked us in and did it and followed the instructions in the article. So I can't complain about the goodwill, but they haven't got the tools. I don't know whether Rosie has microclots. That she quite possibly does, but I don't know of anywhere to get her tested. I'm sure Queen's University in Belfast has the wherewithal. I'm sure the haematology labs and some of the hospitals have the kit that they need to test for it. But how do I, as a parent of a child, organise for that to happen? I don't know. I don't know the pathway in. So, I mean, Rebecca mentioned a consultant who she used to work with, who's been seeing her. Now, we managed to get Rosie onto his list as well. I have no idea when we'll see him. Goodness only knows, but at least that will be on the NHS. I mean, I've spent at least £2,000. Now, yeah, I mean, I'm a professional. I've got a reasonable job, but you know, Rosie's one of 5 children that we have in our house, and this is actually something else I think in response to your question, Lord Strasburger, is I think I would like a recognition as well of the anxiety that this condition is causing our family around us. My wife's upstairs at the moment we have an attic room, it's converted. She's isolating. She tested positive on Friday. So we've been downstairs. We've had all the windows open since Friday. It was -2 overnight. I'm sleeping on the sofa because there's nowhere else for me to go. And Rosie is terrified of getting COVID again and ending up even more broken. And that's not irrational. That's a perfectly rational response to our circumstances, I think. And when I have to send her 8-year-old sister into school, and she's saying like, oh, is mommy going to get long COVID? How do I answer that question? I don't know. I hope to God she doesn't. I really do, because I would not wish this on anyone. It's brutal. It's brutal.
The impression that you're being, to a certain extent, being left to fend for yourselves.
Absolutely, 100%. And I. No,
sorry to interrupt you.
Yeah, no. Go ahead. Go. No, I don't want to hog it. Yeah.
Ravi, any thoughts on support that you need that you're having trouble getting?
Yeah, I think I just want to echo a lot of what Rebecca and Colin said. I think what I need is medical treatment, and that's exactly what I haven't got so far. Psychological support is important. I think stuff like disability benefits is also very important, particularly for a lot of long haulers who have lost jobs and who need to support their families. That personally, that's not so important for me because I'm able to stay at home. But no amount of disability benefits or psychological support will give us our lives back. The only thing that will give us our lives back is medical treatment. Otherwise, we're just having to do what I'm doing at the moment, which is just resting at home most of the day in the hope that I'll get better. But that's a hopeless situation to be in. And in the 21st century, I shouldn't have to do that. So I think medical treatment is the thing which I'd keep stressing as being the decisive thing for us long haulers.
Thank you very much, and back to you, Leila.
Thank you very much. All, if I could pass to Philippa Whitford.
Thanks very much, Leila. Obviously, this is quite a difficult question, thinking about what we've heard from all of you, and I know we are running a bit short of time, but do you feel you, or Colin, in your case, Rosie, is making any progress? And do you see a time when you could get back to normal activity in the future? If I could start with you, Colin, on behalf of Rosie and your hopes for her.
It's very variable. If I'm honest, some days she seems considerably worse than she was a couple of months ago. I don't know if that's because she's abandoned hope. And that's a very hard thing to see in your child. She's on 2 different sets of antidepressants. I don't know. Does it feel like she's getting better? No, it doesn't. I can't answer it in any other way than that. It really doesn't. And when we look around and we see people like Ravi and Rebecca who've been struggling with this for months upon months upon months, it's scary. On the other hand, we do know that people do get better, but we tend not to see them because, the people who are tweeting about this or who are on Facebook talking about it tend to be that group of people who haven't got better, but there are an awful lot of them. And what's frightening, I guess, is the way that Omicron's ripping through the schools at the moment. God knows how many kids we're condemning to this, because children are really suffering from this, really suffering. And Rosie hasn't even got it that bad compared to some. There are some they come out in lesions all over their skin, their teeth fall out, they get blisters in their mouths, their hair comes out, they can't walk. But the narrative is that it doesn't affect children, and it's not true.
I mean, we've seen that, as Leila said at the opening, we've been running these sessions since July 2020, and wave after wave, we've actually seen COVID move down through the age groups and affect younger and younger groups with each wave. So I think the dismissiveness about Omicron as being trivial, I mean, it's not trivial for some people, but also we simply don't know how much long COVID could be coming out of this. If I could come to you, Ravi, next. Obviously, you're one of our youngest witnesses because Rosie couldn't join us. I mean, what's your feeling about when you look at the future?
I think that's probably the most difficult question for us long haulers to face. I know particularly early on in the illness, it was just incredibly difficult to go from being an active person in their 20s to spending all my time in bed. And it was probably one of the most depressing periods of my life because I had no idea whether I'd get better. It went on for days, then weeks, then months, and there was no change. And I was kind of completely despairing. And I thought that this would be my life, that while I had to watch for the rest of my life, my friends live the life I used to live, well, I'd be stuck in bed. Over time, I did learn how to live with long COVID. And for me, that's meant very much believing that I'll get better. Even if the evidence doesn't exist there, it doesn't exist. I think for me, I really have to believe that someday I'll get my life back. And I have seen a little bit of improvement recently. I've been able to reduce the time I spend in bed from 16 hours to 13 hours. And I've also been able to do a little bit more activity. So I've been able to practice the violin for half an hour a day. And that's just felt so good for the soul to kind of get something like that back after almost everything was taken away from me for 10 months. To have just 20 minutes, 30 minutes of music in my day has just, it's been very nice.
As someone who's been learning the cello as an ancient person, I can totally vouch for how therapeutic it is. Rebecca, coming to you, obviously you talked about that we don't have experts in the normal sense because we're still finding our way, but there's a huge amount of research. Do you, because you're in Germany now having new treatment, do you feel more hopeful? And do you think that we need clinics to be connected into research if we're actually going to move forward, so that the patients who are getting support or treatment, whether through the NHS or any other method, we need to be actually learning from the people who recover, the people who don't, what works, what doesn't work? Absolutely.
But I just go back. I feel hopeful that I'm here, that my symptoms may ease. It's not a definite, we don't know that. However, I can't stay here funding this indefinitely to keep that hope alive. And there are so many here who are healthcare workers who are here funding it themselves, like using savings at risk of losing homes. I'm lucky I have a partner who we can keep this going for a short time. But, we need to, if we have the equipment in the UK, what's stopping us getting this up and going here in the UK, rather than just sort of letting people go to Germany and other countries or other clinics just to get that sense of validation and to continue that sense of hope. But, I have to go home. I can't stay. I've come away from my daughters, and that's breaking my heart. So I can't stay here indefinitely for myself, and I can't afford to. But there's surely, as I think Ravi said, we're in the 21st century, we're in the UK, we should be able to have this treatment and reassurance in our own country that, we can get treatment and not be left by the wayside, which is how it feels and felt whenever I was at home. I mean, certainly here, Dr. Yeager is an angel, she is absolutely fantastic, and she is completely invested in her work over here in trying to help long COVID patients, and then hopefully will also help ME patients because they have suffered for decades. We're not new in this sort of chronic condition world, but I mean, why is there not someone like this in the UK taking this on, or even collaborating with her in the UK. I mean, there's doctors here. I've mentioned Dr. Fabrowski. I'm not pronouncing that right, I don't think, but he's from the UK. He could be doing stuff at home, as I say. There's Dr. Asad Khan, who's here, but we're all really unwell. But we're also trying to get answers and help for ultimately it's to help others, that they're here working, trying to do stuff as well. So I'm not sure if that answered your question, but my hope, I don't feel that I'm ever going to get back to normal. I question whether I'll be able to return to nursing. The only maybe way I'll return to nursing is to run a long COVID clinic because I have experience, but I'm not sure if my physical health will let me or my cognitive health will let me. But I think there's a lot we could, and definitely clinics need to be linked with research. I mean, there has to be. We have to invest in that to move this forward, because this. I mean, I'm 21 months down the line. People are 2 years down the line. We can't keep living like this. So we need to get help. We need to get investment into research and appropriate clinics, not clinics for rehab. We need treatment first to then go on to rehab.
Thanks very much to all three of you, and back to Leila.
Thank you very much, all of you. Well, that brings us to the end of this first session. You've given us a huge amount, both in terms of your personal stories, and I just thank you all again for giving us the time and sharing and it's deeply personal and it is heartbreaking to hear. All I can say and keep saying to all long haulers everywhere is that the All Party Group will not stop. We will keep going and campaigning for you in Parliament to get the support that you need and deserve. And thank you all for spending your time and sharing your insights. You are very welcome to stay for the second half, or indeed turn your cameras off and lie down or go entirely. It's entirely up to you. But we do have a really fascinating second half. And so I thank you all for your time. And I'm now going to move to the second panel. Thank you ever so much.
Thank you.
So to answer perhaps some of the questions that were raised in the first half, to give us an overview of where we are clinically, we have a fantastic second panel, and I'd like to thank them all for sparing their time. In sort of order that we're hoping to hear from them, I'll start with Professor Danny Altman. Danny is a good friend of this All Party Group, has spoken to us many times. Thank you for coming back. A professor of immunology at Imperial College London, one of the leading researchers working on understanding why some people have persistent symptoms of COVID-19. So Danny, thank you ever so much for joining us. Second, we're going to hear from Brendan Delaney. Professor Brendan Delaney is a professor of medicine at Imperial College London, who alongside other doctors put together a set of recommendations for recognising and managing long COVID. It was published at the British Journal of General Practice in November 2021. He joined Imperial in 2015 as chair in medical informatics and decision making, and as director of the Centre of Patient Safety and Service Quality. And he's also a practicing GP and has moved things around to be with us today. So thank you so much, Brendan. And last and certainly not least is Dr. Claire Steeves. Claire is a clinical senior lecturer at King's College London. She's also a consultant geriatrician at Guy's and St Thomas's NHS Foundation Trust. And Claire is also a scientist on the Zoe COVID study app. So thank you all. This second session, we've asked a series of questions of our panelists who have then sort of either going to talk to them or flash up some slides and talk to them. And we'll have time for a very brief set of questions at the end. So if we could do it in the order that I introduced you, Danny, then Brendan, then Claire. Over to you, Danny.
Great stuff. So while I share my screen, I'm just to say that, you know, every word that Colin and Ravi and Rebecca said resonates so strongly that all I can do really is sort of put some meat on the bones and add to it. So are you seeing that okay? Good. So a sort of overarching starting point. So like everybody, you know, I get called by journalists and you know, people all the time, you know, are we there yet? Is it over? Has Omicron saved us? And just of relevance for today, a pandemic is a sort of fluid progression. There isn't a day when it's over, and we've been through many phases and many variants, and all of the countries are interlinked, and I think it'll still be a long and bumpy road. In the UK, the situation at the moment appears better under Omicron and more hopeful than it appeared under Delta. But just to remind you, in terms of the discussion we're having today, that we still look to be facing 50,000 or more excess deaths per year. We've got a very heavy outbreak, very heavily skewed to school children who still don't have all mitigations in place in terms of sufficient vaccination, and unclear whether a masks will continue in the coming period. And obviously we have an NHS at breaking point and ill-equipped to cope. And what does all that mean in terms of today's discussion? Well, with respect to long COVID, we already, as we've heard, have a backlog of misery and disease dating back to the beginning of the first wave in 2020, and perhaps faltering and uneven provision to help. And I think we don't really have the data in yet to know how badly we're adding on to that total from the Delta and then the Omicron waves. So this is just a screen grab from the NHS website, but if you look across at the NHS and NICE and WHO websites, we have, I think, the beginnings of convergent definitions of long COVID and the beginnings of a declaration of intent in the UK to offer services. But I think we're a way off the ability to ensure that everybody with long COVID who has those symptoms can access the care pathway that they need. And if necessary, I think something we've got to have a lot of discussions about, the support they need for their disability, irrespective of whether they have formal proof of SARS-CoV-2 infection or not. And 2 years into the pandemic, that becomes a harder and harder discussion to have with certainty, because obviously we now have many people who received no formal diagnosis in the days before we had PCR and antibody testing. And we now have a very complex landscape of people who were infected in different waves by different variants, variably overlaid by vaccines. And it's harder and harder to retrospectively work out what people's infection history was. So this is a slide that I showed you last year, and it's still kind of relevant, isn't it? Because the UK were ahead of the curve in the declaration of intent to roll out long COVID clinics and putting money into long COVID clinics. And yet, all of the questions we've heard about in the last hour, how reliably can you get referred there? Which clinical specialties sit in them? Do we have enough people to sit in them? And where were they trained and what were they trained in? How do we link up that care pathway so there's actually some meaningful specialist support? What kind of therapeutics will they offer to actually make people better? And how many years are we planning this for? And those were big questions a year ago, and they've just become bigger now, I'm afraid. So my impression of long COVID care is that we do have the intent to treat people, but often clinicians running the clinics are working without guidelines and really using their kind of training in general internal medicine to improvise a service from first principles. There are no guidelines, there is no textbooks. So patients across the country get a very uneven experience. And, as we've heard, they don't want rehab or to learn to adjust to acceptance of their disability. They want their old lives back. They really, really do. And this depends on having in place specialist teams, provision, diagnostics and therapeutics. And we are so far from having that in place. The screen grab I show you on the left is for me, a kind of exemplar of a kind of dream team doing that very well. And that's Mel Heitman and Ami Banerjee at University College Hospital. And this was them publishing a paper that I'd encourage you to look at, which is them kind of giving the narrative of their first year's experience of trying to set up and run a long COVID clinic. So to try and speak about some of those gaps, from everything we've heard in the last hour, things would be better if we eased the acceptance and the pathway into long COVID care. And partly that depends on better diagnosis and things like biomarkers and blood tests. So let me speak for a moment about that. So around the world, that field has moved on considerably. And so one point in parentheses, we heard a lot about kind of gaslighting and failure to recognize. Please let everybody in the UK understand that this is a global pandemic, and everywhere that's had this virus has long COVID. And the findings are similar all across the world. There are now many meta-analysis papers reporting that you have the same thing, whether you're in Wuhan or Bangladesh or anywhere else, yeah? Some papers like this one from Australia, the beginnings of the kind of thing that my lab does as well, looking at serum biosignatures that would help to diagnose long COVID. In their case, they came up with this test that if you had strongly elevated interferon beta, gamma, pentraxin, and interleukin-6, that was a strong marker of long COVID. So that's the kind of thing we're all trying to do to get better clues about long COVID. I know that people are very, very anxious to understand mechanism and implications for therapeutics. A lot of people are interested in, for example, microclots. And I think my response to everything we've heard in the last hour is, I so understand the anxiety to kind of get things moving and get the ball rolling and get treatments rolled out. And in that, perhaps I'm just a little bit conservative, that the same way as we had the recovery trial for COVID, let's stick with kind of randomized controlled trials and, proper guided research to just work out what we like best and what works best, and try and do it like that. So to do a bit of immunology, because it's I'm contractually obliged to talk immunology. This is actually not from our lab, it's from a rival lab at Yale. It's from Akiko Iwazaki and Erin Ring. This is the kind of direction of travel. So that thing on the right that looks like a starry night is a kind of heat map of all of the different autoantibodies that come up in people who've been infected with COVID. And what it says is we've got plenty of potential explanation for the pathogenesis of long COVID, because what this virus does is to turn on a massive array of autoimmunity in people who've had it. And it's not very surprising to me that that's linked to the kind of symptoms that we've heard about. So what we're doing in the study that we're just embarking on in my lab is to try and really look properly at underlying mechanism, and without going through all the immunology, that's looking at disrupted immune subsets, it's looking at autoantibody screening, it's looking at programming of T cells, and it's looking at immune responses to the virus itself. And just to make the point that one of the things that's happened since we last met is that NIHR have put quite a lot of money into different studies to look at just the kind of thing we want out of this meeting, underlying mechanism, better treatments. And so we certainly are networked into an enormous number of studies, both nationally and internationally, which I hope has got to be a good thing. But also I know that many sufferers get very cross with us, because it feels like when you set up these studies, they suddenly start to kind of move at a glacial speed as you get all the infrastructure in place and all the contracts in place and all the staff employed. But I promise you, it is moving along. And I think big stuff will happen in the next 6 to 12 months. So to sum up, what do I think about all this, and what are we doing? So, we already have a minimal estimate of 1.3 million in the country with long COVID. And as we discussed before, we don't know the extent that we're adding to this a further running total through the Delta and Omicron outbreak, especially in our schools where Omicron is rampant, and we don't have sufficiently good mitigation, and we don't have sufficiently good vaccine rollout and uptake. And many of the cases we're talking about aren't just the need for rehab. It's it's full-blown medicine with specialist clinical investigation, specialist teams, and specialist treatments. And we haven't thought sufficiently about where the staff and expertise and training and guidelines are going to come from to do that. And my last point, perhaps, is that we have a very large group who acquired a disabling condition through their occupational exposure, especially healthcare workers and teachers, and are now unable to return to the same jobs. They really, really need our consideration, our protection, and our legal support. And it's slightly mind-boggling to me that in the USA, they already have legal protection with long COVID as a disability under the Disabilities Act, and yet neither in the EU nor in the UK do we have that. And that seems very surprising to me. So I hope I've flagged up some additional points, and for the moment I'll leave it at that.
Thank you so much, Danny. That's really helpful. And your word of caution about surging ahead, I think is well understood and certainly heard. Thank you. Next, if I might go to Professor Delaney. Brendan.
Thank you. Let me just share my screen. Good. So I'd point out under disclosures that I personally still have long COVID and had it since April 2020. Quite a lot improved, but still somewhat limited anyway. It's not about me. I'm also co-chief investigator on one of the NIHR studies called Locomotion, which is looking at best practice in clinics, care pathways and general practice. So we've seen and we've heard a lot about this during this morning, but I think the best way of thinking about this right now is over on the right hand end here. We have a lot of symptoms that wax and wane and come back when people think they're better, that may occur in clusters, but there are lots of overlaps between them and they get one symptom and another symptom. And staggering numbers. You know, the recent ONS survey showing more than 500,000 people who've been unwell for more than 12 months. But just to the left of that, potentially treatable things, patterns that we might be able to pick out with these. So we've heard about POTS, which is what's the commonest form of autonomic nervous dysfunction. We've heard about antihistamines. We've got mast cell activation, which that is treating. We haven't heard much about myocarditis and microvascular angina, but there are a group of patients with recognized and proven cardiac and vascular complications. The neurocognitive issues we've talked a lot about. There's a number of studies showing deficits in memory, executive function, particularly issues for the doctors and the teachers involved with this, but also perhaps directly causing symptoms of anxiety and depression, not just secondarily from the effect this has, and as Danny mentioned, effect on work. So what underlies all that over on the left-hand side? I think the bottom line is we don't know for certain, but there are a number of clues that are starting to come through in the international literature. A number of studies showing inflammation of the endothelium, the vascular lining, which obviously affects all tissues. Potentially abnormal microclots. We don't really know the role of those yet, although people are very hopeful about that. Activated platelets, I think that's pretty clear. That's platelets that want to clot rather than just sitting quietly in the bloodstream. And some small studies which show that the fatigue is probably due to the inability of tissues to take up oxygen, because the oxygen that's coming back in the veins after exercise still, so that the blood still has too high a level of oxygen. It has not had enough oxygen extracted out of it. And obviously that can affect any tissue. And you could think that either an abnormally functioning lining of the blood vessels or little blockages and things may be responsible for that. What underlies that? Perhaps persisting viral antigen or virus, autoantibodies, as Danny was saying, some disturbance of the immune system. There's a lot of very detailed work needed to be done to stitch these things together. And perhaps in the brain, there are some worrying studies showing direct viral invasion of brain tissues, problems with blood flow and autoimmunity. So where are we? Thinking at the top of the pyramid, if you like, self-care, peer support. You've heard a lot from the patients, and I think that absolutely reflects the experience of groups. People with long COVID have been looking to support each other, to learn, to understand, to interpret, and particularly the doctors with long COVID have played a large role in that. GPs have a very big role in considering other diagnoses. There's much potential here for misdiagnosis, missed cancers, missed thyroid disease, all sorts of other things, because it's such a common thing. So that's very, very important. And I think it's very important that people with long COVID do go to their GP and don't just say, oh, well, I'm not going to help me, because it really can be something else. Initial management, ruling out the more simple causes. In my own practice, I've had a couple of people with large blood clots in lungs and things that would otherwise have got missed, and then referral as appropriate. The clinics, were based on the plan from the summer of last year. But that local provision has very much grown up ad hoc on the basis of the available staff and skills that each hospital had. And a lot of it's therapy based, a lot of it's OT, physio, CBT. And a lot of clinics were grafted onto clinics that were set up to review people who'd been in ICU. We'll come on to what problem that causes in a minute. And then you've got the relevant sort of general acute medical services, so rapid access chest pain clinics, neurology, etc. And has been pointed out here, not all of the specialists in those areas are really up to speed with thinking about long COVID in the context of their own discipline, and many are dismissive. I won't go over this, I'm sure you've seen this before. This is the NHS England care pathway, but it envisages a lot of this, filtering out other conditions, self-management, and it's only on the very far right-hand end that you start to get into the clinic provision. So what are the barriers? I think self-care is incredibly helpful. From my own perspective, I was able to start myself on antihistamines bought over the counter early in 2020. And it was a lifesaver for me, really. After a couple of months of that, it got me back functioning. So that was from advice from MECFS support groups. The Your COVID Recovery website, which the NHS puts a lot of emphasis on, the phase 1 really isn't at all helpful for long COVID. And the phase 2, you have to go through a clinic to get a referral. So it's very closed. So it's not as open as it can be. GPs are hugely variable, I say as a GP. I'm afraid many of my colleagues are very reluctant to prescribe things off license for treatment of POTS and MCAS and stuff. And I think there's a big educational reassurance issue that needs to come from the NHS and specialists saying, look, okay, we know these are off license, but you need to get out and use them. Our own locomotion project is just starting, but from our initial experience in clinics and from my own experience with patients, I think the issue really with clinics is that across the country there's a confusion between the rehab angle, particularly based on the post-hospital patients, and the need for differential diagnosis and investigation of patients who weren't admitted. Now, these are quite different patient populations to some extent. And a lot of the multidisciplinary teams lack enough medical input. And whilst you do need physio and OT, because I'm not dismissing rehabilitation, it's important, but it needs to be partnered with the medical side of it. And I think there's a lot of missing still, even if you get to a clinic of things like POTS. I have a patient that I've been treating in practice for POTS that was missed by our local long COVID clinic. And they've responded very well to the treatment I've been using. And as I mentioned before, the general medical clinics often lack expertise. We've heard about the tremendous long waiting lists throughout the place. We haven't mentioned Scotland. Scotland has no non-COVID clinics. Wales is only getting going. Northern Ireland is a complete shambles. We were due to have the Belfast clinic in the locomotion project, but they couldn't take part because they've got no funding beyond March to run their clinic. Frankly shocking. So nice guidelines. They updated them just before Christmas. I think this is very, very difficult for NICE. The NICE process involves taking of evidence, chewing it over, digesting it, translating it into guidelines. It's evidence-based. We have very little evidence here. It's emerging, it's patient experience, it's small studies, it's preprints, it's correlations with others. They've tried very hard with the update. They've consulted with the long COVID MECFS communities. They've got in their MCAS, they've got POTS in, which they didn't have last time. It still lacks detail for clinicians. You can't, as a clinician, go to the NICE guidance and say, what should I do? So our paper that you kindly mentioned in the BJGP was got together by a group of about 40 doctors with long COVID. This time last year, when we looked at the first NICE guides and say, this isn't helpful, we can do better. We've been talking about these things. So we did a thing called a Delphi technique to put together some practical guidance. That still stands. I think it's the best practical stuff we could do at the moment. But I think key message is we need to step up on what we call the translational science to get that therapeutic side pushed forward. Back to that in a second. So I was asked to talk about clinics or primary care. Well, I think it's both. And thinking about it, GPs really widely need to step up. There are still, from data from Oxford, 7% of practices where there is nobody coded in that practice with long COVID. So they're either not coding it or they're not considering it at all. It's a big part of our workload. I admit I'm a bit skewed, but I probably see 5 or 6 patients every day I'm in the practice with long COVID. So, you know, it's certainly out there. There are things like POTS and MCAS, which GPs can easily test for and treat. We've heard about the test to do that. It does miss a few people. We need to be a bit careful about that. Don't accept baseline investigations as a rule out. It's not an excuse to say everything's normal. It's clearly not. And with shared decision-making with patients, you can easily move into the off-license therapies. Clinics need to get better. And I think the best way of them getting better is to make sure they all have clear-cut medical specialist input and from a wide range of different specialties, and to see the clinics as being a research centre. We mentioned the UCLH clinic, we've got locomotion. Between us, we've got about 16 clinics. UCLH a bit more than us focused on having funding for that translational activity, but I do think there's a huge gap there that we could leverage on top of that platform to do more work looking around this. And it needs to be done with the same kind of urgency that the acute COVID work, like the recovery trial, was done in 2020. It's like everything's been dropped now. There's no rapid COVID research pathway through NIHR, ethics. You know, we're all struggling with getting contracts and ethics and governance approval sorted without the kind of help. And I ran an acute COVID project, so I know how different that is. Oops, gone back there. So I've left a few references at the end. But happy to answer any questions later. Thank you.
Thank you very, very much. If I can now turn to Claire. If she's there. Or is it?
Apologies, just trying to get my screen up.
Oh yes, of course, don't worry.
Very good. Well, thank you very much. I mean, that was a really great tour de force by everybody else, and I think they've covered lots of things. But just while I'm putting this up, while I'm doing epidemiological research, I'm also actually a clinician that sees people with long COVID as well. I'm sitting in my clinic today, so hopefully this is going to bring it up for you. Where are we? Apologies, you stopped more quickly than I thought you would. Good, can you see that now? So, so my name is Dr. Claire Steeves and I'm a geriatrician, which means that, hold on a minute, there we go, which means that obviously I work in a memory clinic, so that's why I see some patients with long COVID that are referred through to me from long COVID clinics. But my role today in talking to you is really, I'm cohort lead for the convalescent study, which is one of the national core studies, elements of it, looking at long COVID, but I'm also PI on the Zoe COVID symptom study on long COVID. So I'll tell you about a little bit of the research from there. You guys asked me just last Thursday to sort of answer 3 questions. So that's what I'm going to focus on today. The first one is the question, is ONS data a reliable estimate of the number of people living with long COVID in the UK at the moment? And so I'll deal with that as best as I can at the first bit. Then, do we know if vaccines cut the risk of developing long COVID? I'll tell you a bit about our research on that and a little bit of an update as things have gone with booster. Is there a difference in terms of recovery between those who were hospitalised or not? So those are the 3 questions I'm going to touch on, but I'm happy to answer others as well. So I'm going to talk from 3 different sorts of population studies. One is the Zoe app, which is a volunteer population. So it's not completely representative of the UK, but it's really good because it's prospective logging of symptoms. And we've got about 1 million volunteers that have been continuously logging right since the beginning of the pandemic. So that's a very rich data source on this. But then also as part of the national core studies with the cohorts leads, I'm looking at 9 longitudinal national studies with pre-pandemic data. And so that's really been a useful study to look for risk factors for long COVID, but also compared to pre-pandemic symptom reporting. And then we've also, as part of that study as well, been looking at electronic health records of people with a COVID-19 code, which we can sort of contrast against the other estimates. So first of all, I'm going to tell you about the study that we published in Nature Medicine back in October 2020, which was sort of one of the first studies to really look at this in a population level, certainly in the UK. And also it brought out what ends up being really the key factors that determine how prevalent long COVID might be in your population that you might be studying. And as Danny has pointed out, it's prevalent in every population, but depending on these 3 main factors, it might be slightly different prevalence that is reported. So the key things are the severity of the initial infection. And we can see that every study that's looked at post-hospitalized patients, the prevalence of long symptoms, even going out more than a year, is much greater than in those where they've not been hospitalized. That does not mean to say, of course, that people that have not been hospitalized don't get long COVID. It's just that the prevalence is lower. But within our studies, we've seen as well that even in people who are not hospitalized, the severity of that first week of symptoms is really important. So this graphic here is basically a nomogram, which said, and we published in this paper, that if you just take 3 things, the number of symptoms experienced in the first week, the age and the sex of the person, you can get to a model which really quite accurately predicts their risk of going on to get long COVID. And you can use different thresholds based on what you might want to be doing. So if you're doing a trial which might prevent long COVID, you might have a different threshold for treatment. But the point is that using just those 3 things, we can identify people who might be at risk right from very early in the disease. The other factors that influence population studies estimates are about how they've actually determined the long COVID diagnosis or label. And so in the Zoe symptom study, we've had lower prevalence because we've been looking at prospective symptom logging. So we're not asking people retrospectively to consider over their illness. We're actually asking them on a daily basis. And when we've looked at the same groups of people, so exactly the same 2 people, we've looked at prospective logging versus retrospective, we find about a doubling of the numbers of people affected. So in this paper, we found that about 13.5% of people had symptoms for longer than 28 days, prospectively longer, that's continuous symptoms, and 2.3% of people had symptoms for longer than 3 weeks. And when we asked retrospectively, they were approximately double that. But we were very careful to remove, because we could look at the prospective logging, remove people who'd had symptoms prior to their diagnosis. And that was one of the strengths. I think this is another important factor in any studies, that you need to make sure that the study has taken account of baseline reporting of these quite common symptoms. So ONS data. We've already sort of talked about the 500,000 figure, that is people who may be having symptoms for over a year at the moment. But I think on the 6th of Jan, ONS's estimate was there were 1.3 million people in the UK with long COVID. And they used for that their 3rd and most inclusive definition of cases. And I just want to sort of highlight that. So that was 11.4% of people with COVID experienced symptoms for more than 12 weeks. And I think that the advantages of this sort of definition is that the ONS study is a representative sample. So it's built based on the UK population. So that's really good. They had good coverage of symptoms that they were asking about in this particular thing. And also their self-assessed method of assessing long COVID reflected people's lived experience. So people were saying, yes, I identify myself as having long COVID. That was their primary definition. But I think the troubles potentially with this method is that there is a bit of a response bias, in that people who maybe had fewer symptoms may be less likely to be involved in this particular wave of the ONS study. So there could be a response bias. Alternatively, of course, people who are very, very unwell might not be able to respond to the survey. But also they were unable in this analysis to adjust for symptomatology in non-COVID populations. And so we can have a look at how they use different definitions. Basically, what I'm going to show you is that using slightly different definition, they found quite different numbers. So in their first approach, where they actually prospectively asked people about symptoms and then looked to see how many of them were still experiencing symptoms after 12 weeks, it's more like about 5% of people who've had COVID infection. You can see that within the general population, which is these control participants in green, the symptoms reporting within these 12 symptoms that they looked at were substantial, but there is a clear difference between COVID-19 and the general population. And that's something that we also published as well in our original paper, that there's a very clear difference between COVID-19 duration of symptoms and other respiratory viruses that present in exactly the same way, but people have a negative test. So I think that there may be a little bit of overestimation within the ONS figures, putting those things together. Looking in the national core studies, we've asked people about from cohort studies that have been across the UK, and we looked in 10 different longitudinal studies. And our best estimates are that about 5% of middle-aged people are experiencing long-term symptoms that last more than 12 weeks and affect their ability to function as normal. And it's less in younger populations. So it's about 1.2% of 20-year-olds. And overall, that leads to approximately about 3% of the population that have had coronavirus having symptoms that affect their life for more than 12 months. And I think personally, that's probably about where I would sit the best estimate, but these things are difficult to really determine. So here's our projection. So, while I'm saying that that's maybe slightly less than ONS said, what's happened since their data was collected is, of course, the Omicron surge. So we in Zoe have been producing this estimate of the number of new cases every day that is being produced, as it were, by the pandemic curve. Because we've seen in our previous data that there is a very close correlation between the incidence of COVID and then the subsequent development of long COVID symptoms within the app. And so using that best estimate of 5% in the higher age group and 1.2 in the lower age group, we've computed this. And you can see that the real spike that we've just seen with Omicron, that because the numbers of people affected by Omicron was so high, that assuming Omicron has the same rate of long COVID, which we don't know yet, then the numbers will be quite significant that go on to get long COVID now. Obviously, the other thing is there in vaccination. So this graph takes account of the reduced risk, which I'm just about to talk about, that we've identified with after vaccination. But of course, the booster vaccination, I'll talk a bit about that. We think that probably has had an additional helping effect to reduce the risk of long COVID. And that's not taken into account in this graph. But even if Omicron was half as likely to lead to long COVID as Delta, and even if the booster vaccination has some effect, we're still going to see really substantial numbers of people with long COVID going forward. So the story is certainly not over. So putting these together, I think that the 1.3 million estimate may have been a slight overestimate in December, but I think right now that's going to probably be an underestimate. These numbers are still going to be very large and will almost certainly have increased with Omicron. So do we know if vaccines, this was your second question, reduce the risk of long COVID? Well, we published a paper in Lancet Infectious Diseases last October, basically looking at the first couple of months after the second vaccination and comparing to people who are unvaccinated. So we took a sort of case control analysis, and we saw a reduced odds ratio, approximately halving of the risk in people who were double vaccinated compared to matched vaccinated controls, unvaccinated controls. And that's taking account of quite a number of other factors that we think affect COVID risk, like age and so on, as I've said. Now, since we published that paper, we've been looking quite carefully at what happens over time with the second vaccine. And we have seen some evidence, which we haven't published yet, of a slight waning of that protectiveness of the second vaccine over time, month by month, not diminishing back to baseline, And then we've looked at booster. And we haven't published this yet, but we see that the booster vaccination seems to be reducing the risk again, at least with Delta. We can't say yet with Omicron because not enough time has elapsed. So I think that it's really good that we've had a vaccine rollout. I think that's, in terms of prevention of long COVID, going to be really super important. We encourage everybody to come forward for their booster vaccination for this purpose. Now, the last question that you've answered is there a difference in recovery in people who are hospitalized and people who are not? That's something which is clearly evident from the papers that you can see, the review in the literature, that there's a difference in risk. But I just thought I'd show you this study from one of the national core studies, which is cohorts, which contributes to the national core study, which is Twins UK, which is the one I work in. And so within our cohort, we've got 1,627 people that have had COVID across the pandemic so far. And as Danny's pointed out, there are different waves, different strains and things like that, but we can divide them off. But roughly, we haven't seen major differences here in that. But about 30 of them were hospitalized. So it's a small number, 2%. That's not that's about the right rate. And you can see that it's much greater risk of having symptoms for more than 12 weeks in hospitalized groups than non-hospitalized groups. And in fact, much greater risk of having more than 12 months of symptoms in people who are hospitalized. And so I think it's undoubted that that is a key factor, as I sort of said at the beginning. So that's me. I've got lots of other things that I could answer questions on, but those were the 3 questions you wanted me to focus on.
Lovely. Well, thank you so much all. As you've probably noted from the time, we literally have just 2 minutes left, and we've already identified that there are many questions we do want to ask you, and with permission, what we might do is ask them to you over email so that we don't take up more of your time now, and then we will publish both the questions and the answers online later for anyone who's interested to be able to see. And some of those include, why is it that we're seeing some long COVID clinics using ME protocols when they shouldn't be? Another question I have, which I think is partly answered by Claire, is this conversation the country is having about living with COVID and Omicron, a suggestion that Omicron is going to be less severe for long COVID. What's the evidence for that? There was a researcher on the Today programme making that assertion. What's the evidence for that? I think we just don't have time to go into those in the sufficient detail we'd need to now. And so all I'm going to do, in the classic way that we often do, perhaps slightly artificially, is just to say, from your perspective, what is a key recommendation that we now need to make for government as an all-party group? Take a minute each, and I'm afraid we're probably going to have to end it there. Can I start with Danny?
Yeah, it was the kind of point on my last slide that I built up to, wasn't it? That we might get our act together on long COVID clinics and hopefully treatments, but we've still got a very large group of very unhappy people with a new disability, often occupationally acquired, and we need legal remedies for them so that they're not alone in those difficult conversations they're having with HR and so on and so forth. They've got new problems and they need our help.
Thank you very, very much, Brendan.
I think the thing that's really upset me for the whole of the past year is the complete, global gaslighting, I think is the best way I can put it, of long COVID. Everything is about hospital admissions, deaths. The other part of this is long COVID. You have a significant proportion of the population, the working age population, being disabled. Why is that not being counted? Why is it not being taken account of in policy? Why are services and research not being rapidly organised to deal with that? I simply don't understand it.
Thank you very much. And Claire?
Yeah, I would say there is this massive urgency to get therapeutics pathways available for people, and ultimately, GPs, doctors, very, very difficult and very scared to prescribe things, even drugs that are actually, we know are quite safe. Scared to prescribe things without guidance being there. The recruiting to trials being, very specific centres. For example, the HEAL trial is going on. which is doing, I think, what Rebecca's receiving in Germany, but it's only available for some people, isn't it? So if we can really scale up the research into all the long COVID clinics, get them all to be recruiting people for trials across a national way, and really put a massive priority on that so that it happens in the same speed as Brendan said, that it did for long COVID, we can really accelerate this, because ultimately with Omicron, we're going to see a big wave of people with long COVID for sure. And we need to be able to treat them.
Yeah. Well, thank you so much, all of you, for your time. Your expertise shines through. I think we could have spent hours with you, although not that you've got the time, but thank you so much. Thank you also to our first panel again for their personal stories and just putting all of this into the human context that is so important to remember this. Thank you to the parliamentarians, to people watching at home. Well, our next session will be in a couple of weeks' time. Look out on our Twitter feed and other channels for what comes next. We won't be giving up on our campaign to get long COVID recognised and to get people the support that they need. So thank you all again for being part of our session. Goodbye, everyone, and stay safe.
Thank you.